Hello everyone, my name is Salomon Manier. I'm a physician scientist from Lille University in France, and I'm very pleased to discuss the data of the IFM2021-01 TecLille trial. So the trial is focused on the frontline treatment for elderly patients with multiple myeloma, and we know that the standard of care regimens are triplet combination, DRD, or quadruplet combination, such as the Cepheus and IMROSE phase 3 trials. But those regimens are yet remarkable, with between 32 to 61% of MRD negativity at 10 to the minus 5. But of course, the patients will generally ultimately relapse. And so we need to do further optimization of the treatment. So recent combination of Teclistamab and Daratumumab. Teclistamab is the BCMA CD3 bispecific antibody, and Daratumumab is the monoclonal antibody targeting CD38. So this combination has demonstrated a strong efficacy at relapse, and we've seen this at early relapse very recently at ASH with the MajesTEC-3 trial. But most frontline combination evaluate bispecific antibody in a triplet combination together with Daratumumab and lenalidomide, so potentially increasing the toxicity of the treatment. So here we made the hypothesis that a doublet combination with Teclistamab and Daratumumab, which is an all-antibody regimen, will be effective and limit the toxicity in this population of patients, elderly, with newly diagnosed multiple myeloma. So this is study design. It's a phase 2 study, so including patients at newly diagnosed and elderly patients, meaning over the age of 65, who are transplant non-eligible. And they were receiving in Cohort A, which is the focus of this presentation, a combination of Teclistamab and Daratumumab. You can see that Teclistamab was given monthly, starting cycle 2, at the dose of 3 milligrams per kilograms, and Daratumumab was given at the regular dose and schedule. We had a pre-specified safety analysis after the first 18 patients were receiving 2 cycles and before including the rest of the 19 patients. And the primary endpoint was the rates of VGPR or better after 4 cycles. So we screened 38 patients, 1 patient was screen failure, 37 patients were enrolled in the study. So again, you can see in 2 different periods of time, 18 patients were included between March and June 2024. The planned safety analysis was done and favorable. And the second part with 19 patients were included between November 24 and January 25. All patients received the treatment, just 1 patient discontinued due to a side effect. So at data cutoff, the median follow-up was 10.3 months, and with the 2 groups of patients, one with a longer follow-up than the other one. So the median age of the population in the cohort was 73 years. 1/3 of the patients were older than 75, and you can see that 44% of the patients were fit, and 55% of the patients were intermediate or frail per the IMWG frailty score. And you can also see that 1/3 of the patients had a high-risk cytogenetics based on the new IMWG IMS definition. Just 2 patients had extramedullary disease. In terms of efficacy, so the rate of VGPR better was 79% after 4 cycles, so very early. So this is the primary endpoint, and it's a positive study. And you can see that at best response, all the patients achieved at least a VGPR or better, and most of the patients were in complete remission. We evaluated MRD, the minimal residual disease, at 10 to the minus 6 of sensitivity by NGS, clonoSEQ. All patients had an evaluation, but just 27 samples were evaluable due to technical reason. So in ITT, intention to treatment, the rate of MRD negativity 10 to the minus 6 was 73%, but if we focus only on evaluable samples, the rate was 100%. So no patient had a positive MRD in the trial, which is remarkable. We also looked at some biomarkers of tumor burden, the clonotypic mass specs, MINSIGHT on the left, and the soluble BCMA on the right, and you can see a deep decrease of the clonotype and the soluble BCMA after 6 months of treatments. We looked at this immune remodeling after 6 months of treatments, and it was interesting to observe an increase of what we call these terminal effector memory T cells. Those cells are the one doing the cytotoxicity on the tumor cells. So this is linked to the continuous antigen exposure by the bispecific antibody. But we also observed a significant decrease of Tregs and NK cells, and those cells are well known to express CD38. So this is linked to the combination with daratumumab. And I think it's interesting because the decrease of Tregs with the increase of this effector memory T cell describe, I think, quite well the synergy between the two drugs, the bispecific antibody on one part and daratumumab on the other parts. So again, with a median follow-up of 10.3 months, there was no evidence of progression or death, so the PFS and OS rates were 100% both. The dose intensity of the treatment was quite high. In median, the patient had received 12 cycles, and we can see that the dose intensity of teclistamab was 95%, and the dose intensity of daratumumab was 96%. In terms of side effects, 78% of the patient had a grade 3 or more adverse events, no grade 5. It was mostly hematological adverse events, 70% of the case, but mainly lymphopenia and neutropenia. And 27% of the patient had a non-hematological adverse event, and the most frequent was infection. It was 14% of the patients with a grade 3-4 infection in the trial. So on the right side, you can see the adverse event of special interests, infections again. So 65% of infection all grade, but only 14% at grade 3 and 4. And you can see the list of the most frequent or most severe infection observed during the trial. For CRS, the cytokine release syndrome, 59% of the patient had a CRS, but only grade 1 and 2, no grade 3 CRS was observed, and no ICANS was observed, the neurotoxicity in the trial. And so only one patient discontinued treatment due to adverse event. It was a patient with the GI infection due to salmonella. We focused a little bit more on infection just to finish this presentation. And you can see the cumulative incidence of severe infection, grade 3-4, and they're spread across the course of the treatments. And one important information is that we had strong recommendation for immunoglobulin supplementation in the trial, and it was well followed because we can see that 95% of the patients indeed received an immunoglobulin supplementation as soon as cycle 1 in median. And this strategy was able to maintain the IgG level around 7 grams per liter and probably preventing some infection. And we can see that the patients with the red dots who developed a severe infection, grade 3-4, were, except the first cycles, were generally patients with low IgG levels. And we also looked at the CMV reactivation by systematic PCR every 3 months, and we observed only 3 patients with a CMV reactivation, 8% of the patients. 2 were treated, 1 was just observed, and there was no clear correlation between the reactivation of CMV and the count of CD4 T cells. So overall, this all-antibody regimen with teclistamab and daratumumab is highly effective and well tolerated in this elderly population of patients who are transplant non-eligible, and with a median follow-up of 10.3 months. 100% of the patients achieved a VGPR better. All evaluable patients had a negative emerging at 10 to the minus 6 at 6 months. PFS and OS rate were 100%, no grade 3, 4 CRS, no ICANS, and the rate of infection of grade 3 or 4 was 14% with the systematic IVIG supplementation. So we believe that these data support further exploration in phase 3 clinical trial of the frontline combination of BCMA CD3 bispecific antibody and anti-CD38 monoclonal antibodies in the future. So I thank you very much for your attention.